We've had one pandemic end, and we've got this new pandemic of people with persistent symptoms. We started seeing this cluster of people who were expressing different symptoms. The symptoms had changed from, headache and fever and chills and shortness of breath and cough. Now they were talking about dizziness and fatigue, and I can't seem to exercise the way I used to, and there's something about this that I can't shake, and my heart feels like it's beating out of its chest, and my arms are tingling, my feet are going blue. All of these very odd symptoms. Often by the time they made it to our clinic, they're so overwrought that it's a miracle that they're still standing, let alone managing this highly debilitating condition. Now, we're at a point, fortunately, where we feel as though we have a rehab program that is producing results and is somewhat successful in helping people resolve their symptoms. But I will also say that some of our patients who have been discharged for the longest are experiencing relapses. We know that when we increase people's CO2 levels, an edge comes off of their symptoms in most cases. Psychologically, that's a big deal. Just being able to say, I have control over this, as opposed to, I almost fainted and I have no idea why. Finding the right breathwork protocol for the right set of symptoms can sometimes be a bit of trial and error, but these things have measurable physiological effects, and so they can be really powerful.
The coronavirus that causes COVID-19 can spread within days from the airways to the heart, brain and almost every organ system in the body, where it may persist for months. We don't yet know what burden of chronic illness will result in years to come. Will we see young-onset cardiac failure in survivors, or early-onset dementia? These are unanswered questions which call for a precautionary public health approach to mitigation of the spread of this virus. Our results collectively show that while the highest burden of SARS-CoV-2 is in the airways and lung, the virus can disseminate early during infection and infect cells throughout the entire body, including widely throughout the brain. The study provides pathologic data that support findings of previous research showing, for example, that SARS-CoV-2 directly kills heart muscle cells, and that those who survive an infection suffer cognitive deficits. The NIH researchers posit that infection of the pulmonary system may result in an early viremic phase, in which the virus is present in the bloodstream and is seeded throughout the body, including across the blood-brain barrier, even in patients experiencing mild or no symptoms. One patient in the autopsy study was a juvenile who likely died from unrelated seizure complications, suggesting infected children without severe COVID-19 can also experience systemic infection. The less efficient viral clearance in tissues outside the pulmonary system may be related to a weak immune response outside the respiratory tract. SARS-CoV-2 RNA was detected in the brains of all 6 autopsy patients who died more than a month after developing symptoms, and across most locations evaluated in the brain in 5, including one patient who died 230 days after symptom onset. The focus on multiple brain areas is especially helpful. It can help us understand the neurocognitive decline or brain fog and other neuropsychiatric manifestations of long COVID. We need to start thinking of SARS-CoV-2 as a systemic virus that may clear in some people, but in others may persist for weeks or months and produce long COVID, a multifaceted systemic disorder.